Okay, imagine this. Someone intentionally making themselves sick. Or, faking symptoms. Maybe even having unnecessary surgery.
Right, and not for money or getting out of something.
Exactly. Just to be sick. It's quite a baffling kind of behavior.
It really makes you rethink why people usually seek medical help, doesn't it?
It does. And that complex, challenging topic, that's what we're diving into today. We're unpacking factitious disorder.
Also known, maybe more famously, as Munchausen syndrome.
Yeah, exactly. We've got some notes here that really lay it all out, piece by piece.
Covers the whole spectrum, really, from the basic definition right through to management and what the future might hold for someone with it.
So our mission, as always in these deep dives, is to break down this information, give you the key takeaways, the high-yield stuff,
Yeah.
whether you're revising or just fascinated by this.
We'll guide you through the material, highlighting the really crucial bits from these sources.
Okay, we've got it all laid out. Let's unpack this. Where do we start?
Definition, I guess.
What actually is factitious disorder?
Well, what's fascinating here and central is that it's a psychiatric disorder. The person is intentionally producing or feigning physical or psychological symptoms in themselves.
Okay, intentionally is the key word there. They're actively doing this. It's not happening to them involuntarily.
Precisely. And the notes are clear on the motivation. It's about taking on that sick role, getting medical attention, maybe sympathy.
Right, and that's different from malingering, isn't it?
Massively different. Yeah. Malingering is faking for a clear external gain, like avoiding work, getting compensation, maybe drugs.
Okay, so with factitious disorder, the gain is internal. It's the role itself. The notes also mention things like pathological lying, maybe moving between hospitals.
Yeah, those behaviors definitely fit the picture. Simulated illness, lying, that sort of wandering between different doctors or hospitals. The notes also give the other names you might hear.
Like Munchausen's.
Munchausen syndrome, yeah, or sometimes hospital addiction syndrome. And it's named after Baron von Munchausen, the guy famous for telling outrageous, untrue stories.
Oh, okay, that makes sense. The name reflects the deception involved.
It does. And the way it presents can vary. The notes say symptoms can be totally simulated, faked, or someone might make a real illness they have worse on purpose.
Or even induce a disease, actually make themselves sick.
Yes, self-induced illness is part of it. And importantly, the notes briefly touch on Munchausen's by proxy. That's related but distinct. It's where a caregiver fakes or causes illness in someone else, like a child.
Okay, so right away, you see this is much deeper than just, exaggerating a cough to get a day off. It's a real psychological drive.
Which leads straight to the next question. Why? What causes someone to do this? The notes call this the etiology.
Yeah, what does the information say is going on underneath? What are the roots?
Well, the sources describe it as complex. It's usually an interplay of different factors, psychological, social, environmental, not often just one thing.
And they list some specifics. I think I saw childhood trauma mentioned.
That comes up quite significantly, yes. Childhood trauma or abuse. Also, certain personality traits may be being very attention-seeking or needing a lot of control.
A need for control.
That's interesting.
And perhaps a deep desire for, emotional connection or attention.
Yeah.
Which they try to get by being sick.
Seeking connection through illness. Wow. It sounds almost like a really distorted coping mechanism.
It can seem that way. Other things mentioned are maybe having a background in healthcare?
Oh, so they'd have the knowledge to fake things more convincingly.
Potentially, yeah. And just generally having inadequate ways to cope with stress or emotions. The notes even mention it might involve sort of reliving past illnesses or even be a form of self-punishment.
If we connect this to the bigger picture, you can start to see how a difficult past, maybe trauma, difficulty with feelings, it could lead someone to find a strange kind of safety or identity in being the patient.
Right. Now, related to causes are the risk factors. The notes look at who might be more likely to develop this. Okay, so are there specific things that make someone more vulnerable, according to the material?
A lot of overlap with the causes, naturally. Childhood trauma and abuse are listed again. A family history of mental illness, or even factitious disorder itself.
And being in healthcare. That comes up again, too.
Yes, working in healthcare is noted as a risk factor. Again, possibly linked to that knowledge and access.
Makes sense. Opportunity meets vulnerability.
Exactly. Other risks mentioned are personality traits, like impulsivity, that need for attention again, having had lots of hospital stays or surgeries in the past, and just lacking healthy coping strategies for life's difficulties.
The sources mention something about gender here, too, in the risk factors section. that it's more commonly observed in females.
Yes, noted as a risk factor. We'll see how that contrasts a bit with the actual diagnosis stats later on, which is interesting.
Okay, let's shift gears slightly. Pathophysiology. Is there something physical going on? In the brain, maybe?
Yeah, what do the notes say about the biology of it? Is there a specific pathway, like in some other conditions?
Well, based strictly on the source material we have, it's described mainly as a psychological disorder. There aren't really specific, known pathophysiological processes driving it, not like, say, a neurological disease.
So the motivation is psychological, emotional needs. That drive for attention we talked about.
That seems to be the focus in the notes. The need for attention, gratification from the sick role, and the actions themselves, the feigning, exaggerating, maybe self-harm. These are described as conscious behaviors.
Conscious actions, even if the underlying reasons are deep and complex.
Right. And the notes are pretty clear that these specific neurobiological mechanisms, they're just not fully understood yet.
This raises an important question, though, about that mind-body link. Even without a clear physical cause in the usual sense, the mind is having a profound effect on the body, or at least the presentation.
Absolutely. It shows how powerful psychological distress can be. Now, if someone comes in with confusing symptoms, doctors need to rule other things out. Differential diagnosis.
Right. What else could look like this? How do they tell it apart?
The notes highlight three main things to differentiate it from. First, malingering. We mentioned that earlier.
And the key difference there is?
Motivation. Malingering is faking for obvious external gain. Money, avoiding something, drugs, that kind of thing.
Got it. External tangible reward in malingering. Internal psychological reward in factitious disorder. What else?
Second, somatic symptom disorder. Here, the person has real distressing physical symptoms, often without a clear medical cause. They worry excessively about them.
But they aren't faking.
Crucially, no. According to the notes, there's no deliberate faking or production of symptoms. The distress is genuine. The belief they are ill is genuine, even if doctors can't find the physical cause.
Okay, so somatic symptom disorder isn't intentional deception, it's real distress about symptoms.
Exactly. And the third one is illness anxiety disorder. Used to be called hypochondriasis.
Ah, okay. Worrying about
Yeah.
being sick.
Yeah, excessive worry about having or getting a serious illness. Often based on misinterpreting normal body stuff, the anxiety itself is the main problem, not deliberately creating symptoms. So, based on these notes, that intentional deception, specifically to get into that sick role, that's the real dividing line for factitious disorder.
That intentional production seems to be the defining feature. Okay, let's talk epidemiology. How common is this? Who tends to get it?
I'd guess getting accurate numbers is tough, right? If people are actively deceiving doctors.
You guessed it. The notes say it's really challenging to pin down the true prevalence because of that deceptive nature. It often goes hidden or misdiagnosed.
Makes total sense. What estimates do they give?
They suggest it's relatively rare in the general population, but more common in healthcare settings, which fits with the motivation. The estimates in clinical populations vary, but the notes suggest maybe 1% to 5%.
And any particular places in healthcare where it's seen more often?
Yeah. Higher rates noted in psychiatric settings, emergency departments, and specialties that deal with complex or sort of vague symptoms. Neurology, dermatology, places like that.
Fits the pattern. Seeking help for various issues.
And here's where it gets really interesting. Remember the risk factors possibly pointing more towards females?
Yeah.
Well, the epidemiology section in the notes actually says it's more commonly diagnosed in males overall.
Oh, really? That's unexpected.
It is, though it definitely happens in females too. It's mainly seen in adults, typically aged 30 to 50, and most reported cases seem to be in the white population.
Huh. That difference between potential risk factors and actual diagnosed cases?
Yeah.
That's quite telling. Maybe about how it presents differently or gets identified differently, or just how hard it is to diagnose accurately. Really highlights that hidden aspect.
It's a key point from the data provided here. Okay, clinical features. What does this actually look like in practice? What signs might make a doctor suspicious?
This is where it gets really specific. What are the general signs?
Generally, things like vague or atypical symptoms that don't quite fit a known disease pattern, giving an inconsistent medical history. lots of hospital visits, maybe surgeries, sometimes an unusual response to treatments that should work.
Resisting evaluation?
Yeah, resistance to evaluation can be a sign. Or, conversely, sometimes having surprisingly detailed medical knowledge and, like we said, seeking care from lots of different places that doctor shopping.
That seems like a classic flag. And the notes had some really vivid examples, didn't they? Some with dramatic names.
They did, like feigning surgical problems. The notes call it laparotomophilia migrans.
Which means?
Literally something like migrating love of abdominal surgery. Paints a picture, right?
Wow. Repeated unnecessary operations. What else?
Excessive bleeding, termed hemorrhagica histrionica, strange fits, neurologica diabolica, even faking heart attacks, cardiopathia fantastica.
Those names really stick with you. They emphasize how dramatic the presentation can be.
They do. Other examples include inducing side effects from drugs, messing with wound healing so they don't get better, simulating gut problems or breathing issues, self-harm or malnutrition, even using dyes to change skin color to mimic something.
These examples show the sheer lengths someone might go to. It's quite extreme.
Definitely. The notes also list other features to look out for. A long history of unexplained illnesses, those inconsistencies we mentioned, being weirdly willing to have invasive tests, maybe being hostile or dramatic if questioned, exaggerating or being dishonest in other parts of life, having lots of surgical scars. And sometimes, despite reporting severe symptoms, lacking the expected physical signs.
And there's even an online version now, Munchausen by internet.
Yep, same underlying behavior, just playing out in online support groups or forums, seeking that sick role digitally.
These examples, they really stick with you, right? It makes it much more concrete than just the definition.
They absolutely do. So if a doctor suspects this, how do they actually figure it out? What investigations are involved?
It sounds like a diagnostic nightmare.
The notes stress it needs a really comprehensive assessment. Detailed history, physical exams, but crucially, psychological evaluations too.
So not just medical tests, you need mental health input.
Absolutely essential. Collaboration is key. Doctors, psychologists, maybe even legal experts sometimes. The main goal is identifying those patterns of deception, the inconsistencies.
While still making sure you don't miss a real illness.
Exactly. You have to rigorously rule out genuine medical or other psychiatric conditions first. The diagnosis itself uses criteria from the DSM-5, the standard manual. It's classified as factitious disorder.
And Munchausen's is seen as?
Often as a more severe, chronic form of factitious disorder. Both fall under the category of somatic symptom and related disorders in the DSM-5.
The notes had some important tips for clinicians too, didn't they, when they suspect this?
Yes. Like, try to minimize unnecessary invasive tests once suspicion is high. Be aware patients might tamper with samples or records. Look carefully for inconsistencies, but, and this is crucial, remember that someone with factitious disorder can also develop real medical problems.
This raises an important question. How do you walk that line? Balancing suspicion with the duty to investigate potential real illness, especially if the person has this history. That sounds incredibly difficult for doctors.
It's a massive challenge in clinical practice, which brings us neatly to management. How do you treat this once it's identified?
Can't be easy.
No. The notes are clear. Management is difficult. It needs that multidisciplinary team approach. The core is psychological intervention.
Psychotherapy. Things like CBT.
Exactly. Psychotherapy, especially cognitive behavioral therapy, is key. The focus isn't on treating the fake symptoms, obviously, but on the underlying psychological distress.
Addressing the why behind the behavior.
Precisely. Helping the person understand and manage the unresolved conflicts or unmet needs driving it. Collaboration, again, medical teams, mental health, social support. Sometimes hospitalization is needed, especially if there's a risk of self-harm.
Building trust must be incredibly hard, though, given the deception involved.
Hugely challenging. The notes highlight the need to try and build a therapeutic alliance, offer support, but also set really clear boundaries about the deceptive behavior.
And there were some other points about management.
Yes, balancing investigating potential real illness versus addressing the pathological need to be sick. If the diagnosis is clear, confronting the patient might be needed, but sympathetically, while being ready for denial or anger. Psychiatric treatment is vital, especially if trauma is involved. Treating other issues like depression, maybe with SSRIs, can help.
And crucially, not dismissing real symptoms just because of the history.
Absolutely vital. Never deny genuine care needs. The notes also mention practical things, like hospital record systems and how universal electronic records might help spot patterns of doctor shopping earlier.
What's fascinating here is The whole treatment goal shifts. It's not about fixing a physical problem, but about healing the underlying psychological pain that's manifesting in this really unusual way.
It requires a totally different mindset. So what about the prognosis, the long-term outlook?
Given how hard it sounds to get people into treatment and keep them there, I imagine the outlook isn't always great.
The notes reflect that. Prognosis is often difficult to determine, mainly because people with factitious disorder can be very resistant to the psychological help they need.
So it depends on the individual, whether they engage.
Very much so. Influencing factors include how severe it is, the person's willingness for therapy, what the underlying issues are, and how much social support they have.
So improvement is possible.
It is, with the right intervention. But the notes warn that it can often be a chronic condition, and relapse is common. Really addressing those deep underlying psychological issues is key for any chance of long-term recovery.
The notes added some more sobering points on prognosis, too.
They did, mentioning a lack of big follow-up studies or well-tested treatments, suggesting it's still a difficult area, and, really significantly, an increased risk of harm or even death for the person. From the self-harm, the unnecessary procedures causing complications, what doctors call iatrogenic harm, or from withholding important information about what they've done or their real health status.
Wow. So the behavior aimed at getting care can actually lead to serious physical danger.
Exactly. And that final point under prognosis is stark. If someone has a known history of this, they can lose credibility. So even if they later develop a real illness, they might struggle to be believed.
That last point is particularly stark. Their history literally puts them at risk, even when they're genuinely sick. It's a terrible catch-22.
Which leads right into complications. What are the negative consequences?
Well, unnecessary medical procedures and self-harm, we've covered those. They seem like the biggest ones.
Definitely primary complications. Also, the financial cost to healthcare systems from all these investigations and treatments.
And the impact on relationships. The doctors, family.
Well, huge impact. Strained relationships with healthcare providers due to the broken trust, potential legal issues if fraud is involved, like getting drugs illicitly, and it damages trust and credibility in their personal life, too.
So the fallout is really wide-ranging.
Yes. The notes reiterate the risk from self-induced harm, the emotional distress the person experiences, because the underlying pain is real, even if the symptoms aren't, and again, the crucial need for psychological support.
If we connect this to the bigger picture, you really see how this isn't just some medical oddity. It's a serious condition with profound negative impacts on the individual, the healthcare system, their whole life.
A very complex picture with significant human consequences.
Well, that brings us towards the end of this deep dive into the material on factitious disorder. We've looked at that core idea, intentional feigning to be sick, explored the complex psychological roots, seen how incredibly difficult it is to spot.
And discuss the challenges around management and the often difficult prognosis.
We've tried to pull out the key information from these notes, give you that high-yield understanding. Hopefully it helps make this complex condition a bit clearer.
We hope so. Synthesizing this kind of material quickly is what these deep dives are all about.
Absolutely. And thinking about it all, the deception, the internal drive, the risks, the ethical tightrope for clinicians, it leaves you with a lot to mull over.
It really does. And perhaps a final thought. Given how convincing this can be, and the risk of missing real illness later on, how do healthcare systems get better at navigating this? How do you balance that necessary vigilance with the fundamental need to trust and care for patients?
That balance, yeah. That feels like the ongoing critical challenge.
Yeah.
If you are using this for revision or just want to find out more, there are resources available.
Yeah, definitely check out PastMSRA.com and also FreemsSRA.com. Both have great resources for medical learning and revision.
A massive thank you for joining us on this deep dive today. We hope exploring factitious disorder through these notes has been genuinely insightful for you.